Today's topic for discussion is thyroid cancer. It is important to understand the basic anatomy of the thyroid. The thyroid is located in the lower part of the front and sides of the neck. Okay, it consists of two lobes and in some patients the midline pyramidal lobe. And these two lobes are joined together in the center by the isthmus. Each lobe extends upwards to the oblique line of the thyroid cartilage up to the fifth or the sixth tracheal rings below. The parathyroid glands are located at the four poles of the thyroid, two upper and two lower parathyroid glands. These are located in the posterior surface of the gland. And it's important to appreciate their location because they can be damaged during thyroidectomy. Another important structure is the recurrent laryngeal nerve, which passes deep to the thyroid and goes into the tracheoesophageal groove. These two can be damaged during thyroidectomy, resulting in hoarseness of voice or recurrent laryngeal nerve palsy. The isthmus extends across the midline in front of the second, third, and fourth tracheal rings. It is important to realize this anatomy, especially when doing emergency tracheostomy. Okay, the histological structure of the thyroid consists of large number of follicles, known as the thyroid follicles. And each follicle is lined by a single layer of cells known as the follicular cells. And these follicles are filled with substance known as colloid. Okay, and this colloid is where the thyroxine metabolism takes place. In between these parafollicular cells, cells are located cells known as clear cells or C cells or parafollicular cells, which produce calcitonin. This is a close-up view of the follicle. These are the follicular cells, single layer. These follicular cells produce your T3 and T4, which are secreted into the colloid. In between these follicular cells are scattered C cells known as parafollicular cells, which produce the calcitonin. Okay, it's also utmost importance to understand the location or the anatomy of the lymph nodes of the neck. This diagram shows you the 7 groups of lymph nodes that are located in the neck. Level 1 consists of the submental and submandibular nodes. Level 2 consists the upper and middle jugular nodes, level 2 and 3. Level 4 consists of the lower jugular nodes. Level 5, the posterior triangular nodes, which is again divided into lower and upper. The most important as far as thyroid is concerned is the visceral space lymph nodes or the level 6 lymph nodes located in the midline where the thyroid itself is located. This group of lymph nodes are the first to be invaded by thyroid cancers. And the last group is the superior mediastinal or level 7 lymph nodes, which are located in the retrosternal area. This is a lateral view of the same structures. Okay, the 7 groups, levels of lymph nodes in the neck. Okay, classification and incidence of thyroid cancer. There are 4 main types of thyroid cancers. The follicular origin will be the differentiated cancers known as the papillary carcinoma, follicular carcinoma, and Hürthle cell carcinoma. Another group is known as the undifferentiated, which are also known as the anaplastic tumors. The fourth category is the medullary carcinoma, which originates from the parafollicular cells of the thyroid. The differentiated thyroid cancers are the most common. In fact, over 90% of them come differentiated type and come from the follicular cells. Others include lymphomas, sarcomas, and metastatic tumors to the thyroid. As for the etiological factors, there are three main things. One is genetic mutations, the RET genes mutation. The other one is the iodine deficiency, especially in patients with low iodine and iodine deficient coitus. And the third one is radiation, history of early radiation in the younger days or during childhood, or patients who have been subjected to external radiation as well. So this is another group. So the three groups are gene mutation, low iodine levels, and radiation. Now, what are the clinical features? The clinical features of thyroid cancers. First, the symptoms. The most common symptom is a swelling or lump in the neck, either in the front or on the side of the neck. And this lump is usually slow in onset, increases in size rapidly, and is usually painless. Unless it is infected or presses on some either structures, it is usually painless. The pressure symptoms are next common symptoms of thyroid cancer. Hoarseness of voice due to the recurrent laryngeal nerve involvement, dysphagia due to pressure on the esophagus, difficulty in breathing, and stridor due to pressure on the trachea. Hypo and hyperfunction of the thyroid are rarely associated with thyroid cancers. As far as the signs of thyroid cancers are concerned, a lump is the most common finding in most patients. It is often tend to be solitary, but at times it can be multinodular, as in cases of multinodular goiters. The lump is usually immobile and fixed, but it moves with swallowing. It is hard in consistency and usually non-tender. At times, the patient presents with cervical lymphadenopathy, and these lymph nodes are usually discrete in nature and non-metal. Okay, this summarizes the thyroid symptoms. As I say, the nodule, a thyroid nodule is the most common form of presentation. Okay, other presentation includes enlarged lymph nodes, pain in front of the neck, difficulty in swallowing, difficulty in breathing, and persistent cough. I must emphasize the importance of a solitary thyroid nodule. 5% of them, all such nodules tend to be malignant. Okay, so the most important is to have a patient with a solitary nodule, and you have to investigate him for cancer. Okay, this is a patient with a thyroid nodule here, solitary nodule, and the same patient, the nodule, this is before swallowing and this is after swallowing. So it moves with swallowing. And the important thing is, these thyroid nodules or solitary nodules have a 5% chance of being malignant. The most common malignancy is papillary carcinoma. Okay, now we come to the investigations that must be done for patients with thyroid cancer. First, the thyroid function test is very important. Okay, the assessment or assay of T3, T4, and TSH. And it must be emphasized that most patients with thyroid cancer, these functions are normal. Next is the thyroglobulin marker, which is a very good serum marker for patients with thyroid cancers. And this is useful especially in patients after thyroidectomy or thyroid ablation for follow-up of these patients with cancer. And the other thyroid marker will be your serum calcitonin for medullary carcinoma. Thyroid antibodies can occasionally be done in patients with, such as if you think the cause is an autoimmune disease. Ultrasound is the most important preliminary investigation for thyroid nodules or thyroid cancer. Okay, and together with fine needle aspiration cytology, these two investigations in most cases will be sufficient. The ultrasound and the FNAC, or the FNAC, ultrasound guided FNAC, is most of the time sufficient to clinch the diagnosis. Other investigations include CT scan, MRI, and radioiodine uptake studies. Okay, this chart summarizes the physical examination and history, very important, followed by ultrasound, thyroid function test, thyroid iodine scan test, fine needle aspiration, and in patients who are still undetermined whether it is a tumor, then you can do the thyrosequential testing, which is a genetic testing to ascertain whether the nodule is malignant or benign. What are the ultrasound features of malignancy? Okay, the common ones are solid structure, hypoechogenic, irregular margins, absence of halo surrounding the nodule, microcalcifications of the nodule, and lesser common features are central vascularization, the nodule being solitary, and heterogeneity on scan, and the nodules are taller than, with the shape of the nodules is tall, rectangular in shape, and absence of elasticity. Okay, here this is a nodule here, thyroid nodule. This is a benign nodule. You can see the rim around here, and this rim is known as the halo, which is due to pressure onto the surrounding tissues. This is a papillary carcinoma where there is, see the contents here is heterogeneous and the margins are irregular and there's no halo. Same, well-defined margin with benign and ill-defined margin of is a ill-defined margin here. This is a malignant nodule, usually papillary carcinoma, and this is a benign, well-defined nodule with a halo, suggesting it is a benign nodule. Next, we come to the characteristics of some of the tumors or cancers of the thyroid. First, the most common is papillary thyroid carcinoma. The peak onset ages between 30 to 50 years of age. The papillary thyroid cancer is more common in females than in males, a ratio of 3:1. The prognosis is directly related to the tumor size. In most studies, it's found that less than 1 centimeter, the nodule, the better the prognosis. This cancer accounts for 85% of thyroid cancers and it is mostly due to exposure to radiation, especially radiation during the younger days. In more than 50% of cases, it spreads to lymph nodes of the neck. Distant metastasis to the lungs and bones is uncommon, and the overall cure rate is very high, as near 100% for small lesions in young patients. Next, we come to the follicular thyroid cancers, which constitutes about 10 to 15% of all thyroid cancers. It's next common after papillary. It's often difficult to distinguish from benign follicular neoplasms on FNAC. And this is where sometimes you may need thyroid sequential DNA testing to confirm whether it is benign or malignant. Lymph node spread is uncommon. Typical spread is hematogenous, with distant metastasis typically to the lungs and bones. As a variant of this follicular cancer is known as the Hethel cell carcinoma, where the cells are very huge, and these are higher, more aggressive form of follicular carcinoma. The higher rate of lymph node metastasis than classical follicular thyroid cancers. It rarely presents as distant metastasis. However, this high incidence of late metastasis is common. The third group of disease, tumor is the anaplastic thyroid carcinoma, or 8TC. This is an undifferentiated carcinoma, which less than 3% of the thyroid cancers, most aggressive and poorest prognosis. It is usually uncapsulated. Extension outside the gland is common, and it has got a very high mortality, death in several months due to airway obstruction, vascular invasion, and distant metastasis. It is reported to have been higher incidence in pre-existing multinodular goiter. So this usually occurs in older patients compared to the differentiated carcinomas. The fourth category is the medullary carcinoma of the thyroid. This carcinoma originates in the parafollicular cells, and this tumor produces calcitonin. As you all know, the C cells produce calcitonin. But it can also secrete other hormones such as corticotrophin, serotonin, melanin, and prostaglandins. And it is one of the tumors that is considered to be a paraneoplastic syndrome, contributes to the paraneoplastic syndrome with the production of ectopic hormones. The calcitonin in the serum in these patients are usually higher, and it can be used, serum calcitonin can be used as a marker in the follow-up of these patients. Because the tumor does not arise from the thyroid cells, it is TSH independent. Okay, the incidence is around 5 to 6% of all thyroid cancers. In fact, I think it's much less than 3%. And medullary carcinoma may be familial in 25% of cases. And this familial usually affects the children and young adults. The more common sporadic type, which constitutes about 75% of medullary carcinomas, can occur at any age and any sex. The familial type is related to the mutations in the RET, and this type of tumor is known as the familial medullary thyroid carcinomas, MTC. 30% of sporadic MTC have RET mutations. Now we come to the TNM staging. The best staging system is the TNM staging, stage 1 to stage 4. Okay, stage 1 is when the tumor is less than 2 centimeters and without evidence of outside disease. That means it is located within the thyroid lobe, and this is the T1, N0, M0. Stage 2, and the tumor size is between 2 and 4 centimeters, and it is still within the lobe, no extra thyroidal disease. Okay, then this is T2, N0, M0. Stage 3 is when the tumor size is greater than 4 cm, or the level 6 nodal metastasis is positive, or microscopic evidence of extrathyroidal invasion regardless of the thyroid size. Okay, These are the three categories under stage 3. And this is T3, N1, M0. And the last stage, the advanced stage, is stage 4, that there are distant metastases or lymph node involvement outside level 6 group of lymph nodes, or there's gross soft tissue extension. Okay, this is your stage 4 or advanced cancer, and it is very obvious that stage 1 and stage 2 are considered early cancers, whereas stage 4 is considered as a advanced or late cancer, and stage 3 is intermediate.
As for the treatment of thyroid cancers, there are three main modalities of treatment. First, surgery, which consists of thyroidectomy. There are a number of types: lobectomy, subtotal thyroidectomy, and total thyroidectomy. The next is TSH suppression therapy, giving high doses of thyroxine, and this is usually done after the surgery or after the ablation to suppress or prevent the recurrence of the tumor. The third one is radioiodine ablation, okay, giving doses of radioiodine, which is taken up by the thyroid cells, and in the process it kills the thyroid cancer as well. With respect, there are two main markers that must be remembered in regards to cancer treatment, which is given post-operatively on or after radioiodine ablation during follow-up. This is the thyroglobulin, which is a marker for papillary thyroid cancer, and calcitonin, which is a marker for medullary thyroid cancer.
Let's now go through the standard initial treatment, the usual pathway of the standard initial treatment. Once the thyroid lump has been confirmed to be cancerous, we do a total thyroidectomy, which removes the thyroid with all the cancerous tissue that is visibly seen. And then subject the patient to radioactive iodine treatment. This is an ablative treatment which destroys any microscopic residual tissue that may be left behind. Once the patient undergoes both these ablative treatments, the patient is without any functional thyroid tissue. So these patients are completely dependent on exogenous levothyroxine. So these patients have to take thyroxine, and this is known as the thyroxine replacement therapy, which gives the maintenance thyroxine for the patient's bodily functions. Treatment of thyroid cancer, the surgical treatment. What does the surgical treatment involve? The initial treatment is total thyroidectomy. Once you've confirmed it's a thyroid cancer, you do a total thyroidectomy with or without the central neck lymph nodes, depending on the patient, whether it's a low risk or high risk. You may consider hemithyroidectomy or lobectomy if a single focus of papillary cancer less than 1 cm is located within the thyroid gland, intracapsular. These are the low risk cancers. More extensive resection for the patients with evidence of neck invasion of the neck structures or lymph nodes may have to be carried out if the patient requires. The surgical risks include of total thyroidectomy include hypoparathyroidism and recurrent laryngeal nerve damage, and also hypocalcemia due to the hypoparathyroidism, which may require the patient extra stay in the hospital. Now, what are the types of thyroidectomy that are usually done? Okay, first is lobectomy, which is the removal of a lobe of the thyroid which bears the tumor plus the isthmus if necessary. Subtotal thyroidectomy, where both the lobes of the removed, but a little bit of tissue, about 5 grams, is left behind on either side, usually at the upper lobe. That is subtotal thyroidectomy. The third one commonly done is your total thyroidectomy, where there is complete removal of all visible thyroid tissue. And sometimes this may also include removal of the level 6 or the central cervical lymph nodes. Some people do near total thyroidectomy. That means you remove one side, total lobectomy, and the other side you just leave behind a rim of tissue on the contralateral side. And these types of thyroidectomy can be either done by 2 methods, open or minimally invasive. Okay, the first here, these are the types of thyroidectomy that is being done. The first one here is the lobectomy. Okay, the lobe is removed with or without the isthmus. Okay, and this is usually performed for early tumors when the tumor is small and intracapsular within the thyroid. It does not penetrate it. So this is also known as hemithyroidectomy. The next is subtotal thyroidectomy, where you can remove both the gland, right and left lobes, but leave behind a small rim of tissue on the side where the lobe is normal. Okay, but however, a lot of people prefer to leave behind a small tissue in either lobes, upper lobe. This is to ensure the preservation of the superior parathyroid glands to prevent hypoparathyroidism post-operatively. Okay, so in this case, parathyroids are spared by doing this. And the last one is your total thyroidectomy, and the entire gland is removed. Okay, and the procedure is known as total thyroidectomy. But in this total parathyroidectomy, there's a higher risk of removing the parathyroid as well. That leads to hypoparathyroidism and hypocalcemia postoperatively. Also, the injury to the recurrent laryngeal nerves are also much higher incidence in these patients. So in these patients, the recurrent laryngeal nerve and parathyroids are at risk, okay, in patients undergoing total thyroidectomy. Okay, most of the operations are still being done thyroidectomy by open method, that means using a collar-like incision over the front of the neck. Nowadays, more and more patients with the facilities available, minimally invasive method is being used, and this is known as the minimally invasive video-assisted thyroidectomy, or MIVAT, M-I-V-A-T. The advantages of this MIVAT is it's a keyhole surgery. There are no major scars, so it's cosmetically more acceptable, and also the neck muscles are not divided, thereby post-operatively there is less pain, and also the movement of the neck is much better after the operation. The disadvantage is it's a very long procedure, elaborate training is needed for the surgeon, and it's not very widely done, and it's costly. Now, whatever the method of thyroidectomy, the complications are similar. So what are these complications? And these complications are especially more common after total thyroidectomy compared to lobectomy. They are hemorrhage, which can lead to post-operative stridor and respiratory distress, requiring emergency intervention. Hypoparathyroidism, when you remove accidentally all the parathyroid glands, so the patient becomes hypocalcemic. This can lead to post-operative hypocalcemia and tetany, which also requires immediate attention and treatment. There can be damage to recurrent laryngeal nerve, which leads to vocal cord paralysis. Vocal cord paralysis. Not just not hoarseness, but if it is complete section, then it leads to vocal cord paralysis. Now, of course, as it is a cancer, the distant metastasis is another major complication. And the distant sites are usually liver, lungs, and bone.
Okay, next we come to radioactive ablation of the thyroid gland. This is based on the principle that iodine specifically is taken up by the thyroid cells, cancer as well as normal thyroid follicular cells. And if radioiodine is given, this is taken up by these thyroid follicular cells, thereby destroying the cells. First, how is it done? Radioiodine nowadays is given through a drink or capsule. Okay, radioiodine is ingested, and these radioiodine molecules are absorbed through the intestine and then reach the bloodstream. Once in the bloodstream, is taken up by the thyroid gland, okay, which needs iodine for its function. So the follicular cells will absorb this thyroid, radioactive thyroid, and that leads to destruction of the cells. You must understand radioactive iodine destroys not only the cancerous thyroid cells, it also kills the normal cells. Radioactive iodine therapy is used for hyperthyroidism and also, most importantly, in thyroid cancers, especially for the prevention of recurrences and post-operative treatment. It is also useful for metastasis, where this iodine is taken up by these cancer cells and thereby cause destruction of those cells.
Now let's look at the principle of the TSH suppression therapy for thyroid cancer. This is usually done for patients after total thyroidectomy, where the thyroid cancer has been removed and that patient has without any functioning thyroid tissue. As a result, patients is given replacement therapy, and this replacement therapy normalizes the TSH. Otherwise, the TSH tends to increase to stimulate more production of more thyroxine. So if the replacement is not enough, then what happens? The increased TSH will stimulate the existing thyroid tissue, and that will cause the recurrence of the disease. So in order to prevent further, you have to suppress the TSH from stimulating any microscopic focus of thyroid tissue that may be available, and this is known as the suppression treatment, TSH suppression therapy, where a higher dose, which you give the patient a higher dose of thyroxine to suppress whatever TSH that may be produced. And this suppression of the TSH decrease the risk of recurrence of thyroid cancer. Okay, so there's a replacement therapy and suppression therapy, TSH suppression and thyroid replacement therapy. This thyroid hormone feedback loop further explains how the TSH suppression prevents the stimulation of the thyroid. Okay, you all know thyroid is stimulated by the TSH, thyroid stimulating hormone, from the anterior pituitary. And the anterior pituitary is in turn stimulated by the hypothalamus with its hormone, the thyrotrophic hormone. Thyrotrophic hormone stimulates release of TSH, and TSH stimulates the thyroid to produce T3 and T4. This T3 and T4 in turn have a negative feedback on the anterior pituitary as well as the hypothalamus, whereby by increasing this T3 and T4 in the serum, the TRH and TSH are suppressed. And this TSH suppression is the basis of the TSH suppression therapy for cancer patients, thyroid cancer patients. Okay, so for thyroid suppression, it's usually used after thyroidectomy and radioablation for thyrotoxicosis, for example. Reduces the tumor growth and recurrence rates after surgery. The suppression dose is 0.3 milligrams per day for lifelong, whereas the maintenance dose is only 0.1, okay, 0.1 milligrams. In monitoring these patients, it's very important to monitor the TSH levels. These TSH levels must be kept less than 0.1 microunits per liter. Okay, so as long this TSH level is within this level, less than this value, then there's adequate suppression with TSH for long-term suppression or prevention of recurrences. So what are the things that determine the survival rate of these tumors? Okay, the prognosis is basically in accordance with the histological type, follows the histological type of the lesion. The differentiated cancers have good prognosis. Okay, as I said, papillary, which accounts for more than 80% of the tumors, can have a 10-year survival as high as 93%. In fact, nowadays there are people talking of cure rate of 100%, not survival rate anymore. The follicular and Hurtle cells are also not very far behind. Whereas the anaplastic tumors, the undifferentiated tumor, has very poor prognosis. Okay, fortunately, it constitutes less than 1% of the thyroid cancers. It is very aggressive, rapidly invasive, with a median survival of 4 to 5 months from the time of diagnosis. Some special features of thyroid cancers. Thyroid cancers affect a relatively young group of patients and the prognosis is good. The tumors are slow growing, very rarely they metastasize. If they do so, it is very after a long period. Early diagnosis is possible and good and effective treatments are available. Because of this good prognosis, the traditional concept was to go aggressively with total thyroidectomy and lymph node clearance. However, today it is believed it is most of these patients, especially with small tumors, may not need such aggressive management, which has got its accompanying complications. The new trend is to divide the cases is low risk and high risk. Low risk are those patients with tumors less than 1 centimeter, localized and intracapsular. High risk is when the tumor size is more than 1 cm, multifocal and extracapsular. So the new concept is to be more conservative treatment of the low risk cases to avoid radical treatment for those who do not need it. For low risk patients, especially the differentiated thyroid carcinomas, lobectomy alone will be sufficient. Whereas for high risk cases, you may need a total thyroidectomy with or without lymph node clearance, followed by radioablation.